Hello, my name is David Marlevi, and thank you for the opportunity to present our collaborative work using Flow MRI to predict growth in aortic dissection. Type B dissection is predominantly a chronic disease, which is often complicated by progressive growth of the false lumen of the dissected descending aorta, leading to significant morbidity and poor long-term outcomes. Endovascular treatments have been shown to improve mortality in these patients. However, these surgical techniques are most effective when applied to patients at highest risk of growth. Current methods to predict growth rely on measuring maximum aortic diameter. However, it is becoming increasingly evident that the aortic diameter is an ineffective predictor of growth. To exemplify, in a recent systematic review of about 50 publications, diameter was only indicated as a predictor of growth in about half of these. This problem is highlighted above to the right, where two patients with similar baseline diameters experienced vastly different degrees of growth at 1 year follow-up. Thus, there remains a significant need for techniques to better understand and predict growth in patients with type B aortic dissections. Aortic growth is instead a dynamic process driven by a combination of factors including hemodynamics, biomechanics, and biological factors in the aortic wall. Among these factors, hemodynamics remains one of the most easily accessible ones in patients through the use of Flow MRI. In particular, numerous studies employing a variety of techniques have highlighted the important role of false lumen pressure in promoting aortic growth. And as such, Flow MRI has the potential to add prognostic value for patients with type B aortic dissections if used to extract false lumen pressure. So the aim of our work was therefore to use Flow MRI to extract different measures proposed to describe false lumen pressurization in the clinical cohort of dissection patients. Furthermore, we aim to evaluate the independent association of these metrics with the aortic growth and compare them against routine diameter measurements. So to do this, we analyzed MRI data from 12 patients with descending aortic dissections. The cohort was classified into two subgroups, one with enlarging dimensions, meaning an aortic growth rate of at least 3 millimeters a year, and one with stable dimensions. To quantify the 4D-flow output, the false lumen was segmented on contrast-enhanced images and then co-registered to the 4D-flow space in a semi-automatic fashion. To then estimate false lumen pressure, we analyzed several different metrics having been proposed in literature, some direct, some indirect, some extrapolating false lumen pressurization from regional assessments, and others incorporating global behavior of the entire false lumen. In our instance, we chose to extract three different metrics. First, we calculated the false lumen ejection fraction, or FLEF, defined as the ratio between retrograde and antegrade flow through the dominant dissection tear. Intuitively, as the false lumen pressure increases, both the retrograde flow fraction and FLEF will increase. Second, we measured maximum systolic deceleration rate, or MSDR, defined as the average deceleration rate between maximum and minimum acceleration in a proximal segment of the false lumen. Again, as false lumen pressure increases, resistance to flow will increase and the deceleration will become more rapid. Lastly, we used a previously validated technique based on the virtual work energy principle to extract maximum relative pressure, or the pressure difference, between aortic inlet and the distal false lumen of the thoracic aorta. Here, with increasing false lumen pressurization, the relative pressure difference between the ascending aorta and the distal false lumen will decrease. So coming to the results, we can start by looking at standard anatomical characteristics as shown here for both the stable and enlarging aortas. Of note, mean aortic diameter was slightly higher at baseline and follow-up in the enlarging group, although these differences didn't reach statistical significance. However, if we look at our measures of false lumen pressurization, we noted that FLEF was significantly increased and false lumen maximum relative pressure was significantly decreased in the enlarging subgroup. We did not identify significant differences in MSDR between the two groups. FLEF and false lumen maximum relative pressure both showed moderate to strong correlations with the aortic growth rate, whereas MSDR and baseline diameter demonstrated weaker, non-significant correlations with growth. Furthermore, after adjusting for diameter, FLEF and false lumen maximum relative pressure were both independent predictors of growth. So summarizing, we have extracted and presented three different entities to describe false lumen pressurization, FLEF, MSDR, and false lumen maximum relative pressure. So with our data in mind, we can propose a conceptual model of how these parameters relate to false lumen pressurization. So in the state of low false lumen pressure and no growth, we see no significant retrograde flow, deceleration is modest, and relative pressure approximate values but would be seen in a normal aorta. However, as pressure and growth increase, we expect changes in our three parameters. Specifically, pressure overload increases retrograde flow through the opening tear, and thus FLEF increases. It decelerates blood more rapidly, and thus MSDR increases, and finally, it decreases the relative pressure difference between the ascending aorta and the false lumen. So even though we believe these three metrics all describe the same phenomena, they do so by utilizing different entities of the hemodynamic environment and consequently come with unique strengths and weaknesses. For FLEF, it is the entity that in our data showed the strongest correlation with growth, and it is also a simple metric to derive. All that is required is identification of the high velocity flow at the entry tear. However, FLEF is only an indirect estimate of pressure, does not take any distal false lumen behavior into account, and is based on flow analysis and a 2D analysis plane, which can be problematic in complex tear anatomies. MSDR in our study was not significantly correlated with growth. However, this may be due to our small sample size, as significant associations have been shown in larger cohorts. Instead, we noted fairly high degrees of variability in MSDR, possibly owing to the fact that MSDR is reliant on second-order time derivatives of flow, as such being a fairly noise-sensitive entity. Similarly, secondary flow features such as helices and vortices, which are common in aortic dissection, will possibly affect MSDR measurement. Lastly, extraction of false lumen relative pressure is the most direct approach for assessing false lumen pressure, and it allows for a more global assessment compared to the other two metrics. However, drawbacks of this approach are the need for false lumen segmentations, which can be difficult in the setting of slow flow, and the more complex nature of the implementation. So in reality, given the strengths and weaknesses of each metric and the fact that they can all be derived from the same 4D flow dataset, an optimal approach for understanding may involve multiple metrics. So regardless of metric, our results further add to the increasing body of evidence highlighting the role of false lumen pressurization, especially as compared to the clinical standard of maximum aortic diameter. So we envision larger cohorts to extend our inferences, as well as to couple data to clinical outcome. Overall, our results do, however, highlight the predictive value and additional prognostic information provided by Flow MRI, where aortic dissection is a prime example of where treatment strategies and patient management could benefit from flow quantifications, as showcased in this presented work. Thank you for your attention.